This is Eric Fishman for EHR TV. We're at HIMSS10, and today we're speaking with Dan Polino, General Manager of Healthcare and Life Sciences at IBM. And Dan, I thank you very much for taking your time today to speak with us. Tell us about IBM and how it interfaces most particularly with the small medical practice. The majority of physicians are in small practices, 1 to 5 or 1 to 10 doctors, and obviously IBM has a very, very large footprint in hospitals and in patients. But our concentration will be the 1 to 10, 1 to 50 doctor practices. So tell us how a physician might be able to utilize your services.
Yes, thank you. One of 3 ways. One is with the small primary care, the small office, working on their own, looking for maybe an operational model versus a capital model, to have an EMR included within their workflow and process. And they might turn to IBM to say, what are my available options? These could be hosted solutions, working with partners that are out there, usually very affordable on a per month basis, on potentially a per member basis, very affordable, looks at the entire workflow and process, integrates the workflow that's associated with that office. So that's one way. That way is relatively inexpensive and creates an option by which you can pay on a per month basis.
And so just to be clear, IBM does not sell the EMR, but you know a lot about the industry and can point the small practice in the right direction.
Right, we do not sell an EMR. We actually bring EMR partners together and work very closely with them, looking not only at the EMR itself, but also scheduling, the ability to do adjudication, eligibility. We think there's roughly 32 applications that are within a doctor's office, and as we can integrate these better into a monthly type of subscription on a cloud type offering, we think that's a way that's very affordable for the doctor, works as with their workflow and process they have today, and it's very affordable.
For small practice, completely agree. And now you said 3 different methods, and I think we've covered the first.
Right, we talked about the first one. The second is a doctor office, small doctor office, may decide to integrate in a clinic into a larger organization. Maybe they want to scale the scheduling, maybe they want to scale the EMR, maybe they want to scale insurance and claims.
Not to misuse a current word these days, but there's a tidal wave of that.
There's absolutely a tidal wave of that, and the reason is because you see benefit, and you'd like to maybe still keep your ability to perform independently from any of these hospital systems, but yet be able to have a referral network. So you join into a clinic. There's many of these that are expanding. And then the third, of course, is the affiliation, and we're seeing significant growth.
And I understand you have an affiliation, for instance, with the AAFP. There are 90-some thousand members, and tell us about that.
Right. The American Academy of Family Physicians, as they start to look and make recommendations, they're supporting, of course, the medical home.
Right.
So what they're looking for is solution sets that address the medical home, allow you to be NCQA Level 3 certified. There's some funding mechanisms that are appropriate there. Also, the health plans are looking for doctors that are certified within medical home. They know that if they put members into those systems, they have better quality metrics coming out based on the initial peer reviews that we've done. And so you have many people that are looking for those type of infrastructures, those IT infrastructures that allow you to be NCQA Level 3 certified, perform at the medical home. And the American Academy of Family Physicians and the ACP will be able to help guide and direct you.
I think there are a lot of our viewers who probably are not that familiar with the term medical home, and if you could spend a few moments discussing that.
Sure, the medical home is the thought around continuum of care with a team care model. This allows doctors, caregivers, nurses, etc., to perform at their highest level of their license, looking at the patient in totality. Within this, then you start to think about the client and the patient as an extension of how your system works. Instead of that acute or episodic condition, what you're looking for then is, how do I treat that patient from a continual experience? Ensuring that they're taking the right kind of medications, that they're adhering to whatever you've asked them to do. We could, in fact, maybe address even behavior. So it's not just an episodic or acute 15-minute discussion that you have, but you're actually thinking about that patient on an extended view.
I think there are a lot of people here in Atlanta today who are very happy that the American healthcare is taking this direction. Maybe even some in Washington believe that this is an appropriate direction.
Absolutely. The work that we've done so far and the pilots that are out there have showed just tremendous benefit. I'll use one example. Community Care of North Carolina. One disease condition, asthmatics, population base of 750,000 people. Their goal, keep asthmatics out of the emergency room.
Of course.
And what it showed was they were able to save $150 million out of 750,000 people.
Okay.
750,000 people, population base, one condition, asthmatic, and be able to keep them out of the hospital. If you can do that in Eastern Carolina, and that was the population base, just think what we could do across the state. That's the benefits of a medical home.
And that's clearly a direction we are and need to be going on. Commend IBM for doing that. I understand that the United States is one small part of your market, and I've been told that there have been 3,000 transformational projects that have been done by IBM, such as the entire country of Denmark.
Yes.
Can you, and we've been speaking about the small scale, just for a few moments, talk about some of the larger scale projects that you've done?
Sure, and thank you for mentioning that to us. We do run the healthcare system for Denmark. Denmark is actually 5.5 million people. And when you look across 5.5 million people, believe it or not, that looks like a region in the U.S. In Denmark, we've been able to focus on primary care, chronic conditions, and they have a different mix than we do of specialty versus primary care. As a matter of fact, they're just the opposite of what we are. They're 75% primary care, 25% specialty. Also in Denmark, they went from 155 hospitals to 25 hospitals. So you can actually see the compression, and as you know, Denmark is the best performing country when you look at all the metrics for healthcare. So if we were to look to them, the ability to be able to put an integrated delivery system with primary care at the front end allows you to have a better healthcare delivery system, and it actually is less expensive.
The International Bar Association, the IBA, is having a healthcare IT meeting in Denmark this May, and I'm now understanding why, in fact, it may be in
Yes,
Denmark.
as a matter of fact, in talking with Dr. Blumenthal, he actually sent a delegation over to Denmark to study what's been happening there. And the very fact that if we can do it in Denmark at 5.5 million people, what's to stop us from doing it in the major regions within the U.S. and potentially expanding it in a broader level?
I think the answer is not very much, and I think it may be happening.
I think it is, and that's the exciting part.
Thank you very much. I thank you for your time.
My pleasure.
I appreciate it.
Yeah.
This is Eric Fishman. We've been speaking with Dan Polino, General Manager of Healthcare and Life Sciences at IBM. Thank you.